Walk into any emergency department in the world, and you will hear clinicians rapidly categorize patients using a single ubiquitous phrase, the acute abdomen. It is a shorthand meant to instantly identify a surgical emergency. It is also entirely flawed. Correctly diagnosing abdominal emergencies requires navigating a strict clinical paradox. The most catastrophic, life-threatening events, like a slowly necrosing bowel, are often heralded by the subtlest of physical signs. Conversely, patients presenting in absolute sheer agony, writhing on the examination table, frequently have benign, self-limiting disease processes. This is why clinical literature explicitly rejects the diagnosis of an acute or surgical abdomen. The text provides a definitive warning. Subjective pain severity does not necessarily correlate with the severity of the underlying condition. Relying on a subjective 1 to 10 pain scale in this environment is dangerous. A clinician waiting for a patient's pain score to hit a 9 or a 10 will inevitably miss fatal, slow-onset emergencies until it is too late to intervene. To safely triage these patients, we have to abandon subjective scoring entirely. The clinician's job is to reverse engineer the exact physical character of the pain back to its specific pathophysiologic mechanism. That reverse engineering process starts with a fundamental anatomical duality. Almost all abdominal pain mechanisms originate from one of two completely different structures: inflammation of the parietal peritoneal layer or the mechanical distension of a luminal tube. Parietal peritoneal inflammation operates through somatic nerves. These are the same highly precise nerve pathways that supply the skin and skeletal muscle. Because of this somatic wiring, parietal pain is steady, aching, and intensely localized directly over the inflamed area. This somatic pain is driven by a sensitivity to tension. Any pressure, palpation, or sudden movement that stretches the inflamed peritoneum will sharply increase the patient's discomfort. At the bedside, this creates a classic presentation. A patient with peritonitis will characteristically lie perfectly still, avoiding any motion whatsoever, trying to prevent even the slightest shift in their abdominal wall. The onset of this posture depends heavily on the specific irritant. Sudden exposure to sterile, highly acidic gastric juice triggers this immediate, severe somatic response. However, gross fecal contamination may go entirely unnoticed until bacterial multiplication finally triggers enough inflammatory mediators to irritate the lining. Compare this entirely with the second mechanism, the mechanical obstruction of hollow viscera. Luminal distension is transmitted by visceral nerve pathways. These pathways are far less precise, lacking the tight point-to-point mapping of the somatic system. Consequently, the character of visceral pain is completely different. It is classically intermittent, cramping, and colicky, rising and falling as the bowel attempts to force its contents past an obstruction. Unlike the pinpoint accuracy of parietal inflammation, this visceral pain is poorly localized, often presenting as a vague, diffuse discomfort around or above the umbilicus. Lacking the strict tension sensitivity of peritonitis, the patient with an obstructed viscus behaves entirely differently. They are typically restless, pulling their knees to their chest and continuously thrashing in bed to find a comfortable position. Before you even place a stethoscope on a patient, their physical posture in the bed, rigid stillness versus restless thrashing, gives you the first, most reliable readout of which underlying tissue layer is failing. Understanding these physiological pathways is critical, because relying on traditional clinical nomenclature will actively mislead your diagnostic process. Consider the term biliary colic. It is a deeply entrenched phrase used to describe gallbladder issues, but the text explicitly calls this a misnomer. True colic is intermittent and cramping. Sudden distension of the biliary tree actually produces a steady, continuous ache. Expecting intermittent pain based on the name of the condition will lead you away from the correct diagnosis. A far more dangerous misconception concerns vascular disturbances. There is a persistent assumption that occlusion of the superior mesenteric artery will immediately present as sudden, catastrophic pain. The actual timeline tells a different story. For the first 2 to 3 days after the occlusion forms, the patient typically experiences only mild, continuous, diffuse pain. This early, seemingly insignificant discomfort is not caused by tissue death. It is driven mechanically by hyperperistalsis, as the bowel aggressively reacts to the initial lack of blood flow. The true hallmark clinical sign during this critical window is severe pain that is entirely out of proportion to the physical findings. The abdomen remains soft, without tenderness or rigidity, masking the severity of the arterial blockage. The classic agonizing signs of peritoneal inflammation, the rigid abdomen and rebound tenderness, only appear at the final stage of the process, immediately preceding total vascular collapse. If a clinician waits for catastrophic pain to confirm a vascular event, the diagnosis is confirmed exactly when the bowel becomes unsalvageable. Even when physiological pathways are functioning, you must account for populations where these classic pain mechanisms are attenuated or entirely absent. Patients receiving immunosuppressive treatments, high-dose glucocorticoids, or those living with AIDS are at extremely high risk. In these patients, unusual infections from cytomegalovirus or mycobacteria can cause completely occult, silent perforations of the gastrointestinal tract. The extreme elderly also fall firmly into this category. Normal physiological responses to catastrophic inflammation are frequently masked, leaving the clinician with a severely muted physical presentation. This table outlines the structural matrix required to manage an undifferentiated patient when those classic signs fail or are masked. By mapping the location of the pain to one of the 4 abdominal quadrants, you establish an initial framework. This simple spatial filter immediately narrows dozens of potentially fatal etiologies down to a workable, localized list. However, the text provides a vital caveat. While anatomical mapping is a necessary starting point, spatial location is not the most important diagnostic factor. A precise chronological sequence of how the symptoms evolved is the single most important data point for confirming the final etiology. Extracting this sequence requires abandoning rapid anatomical mapping for a meticulously detailed patient history. Knowing exactly what happened and in what order changes the differential. Establishing definitively if nausea preceded the pain or occurred as a reaction to it dictates the next clinical step. When transitioning to the physical exam, the text mandates absolute gentleness. Pressing deeply into an inflamed abdomen and suddenly releasing is strictly condemned. The text explicitly labels this aggressive technique as cruel and unnecessary. There is a superior, precise alternative. The exact same clinical information can be obtained by gentle percussion of the abdomen. Tapping the surface lightly tests for rebound tenderness on a miniature scale without causing extreme distress. Furthermore, simply asking the patient to cough will elicit true rebound tenderness automatically, requiring no hands on the abdomen whatsoever. Aggressive palpation actually destroys the physical exam. It forcefully induces a protective, voluntary muscle spasm in a worried patient. Once voluntary guarding sets in, assessing the underlying involuntary muscular rigidity of peritonitis becomes impossible. A brusque, heavy-handed examiner actively corrupts their own clinical data. Standard laboratory workups have severe limitations. Leukocytosis should never be the deciding factor for surgery. Completely normal counts are common, even with severe perforation. Imaging has evolved. Low-dose computed tomography is decisively preferred over plain radiographs when evaluating non-traumatic acute abdominal pain. Yet, even with advanced imaging and complete blood panels, there are times when a definitive diagnosis simply cannot be established during the initial examination. In these undifferentiated cases, safe clinical navigation requires a return to first principles, a meticulously detailed history, an expert understanding of nerve pathways, and a protocol of watchful waiting with gentle, repeated physical exams.